I was planning to look into some other endovascular and percutaneous techniques in interventional oncology, just for you to have an idea how the landscape is changing. This is the presentations, vascular presentations and oncology presentations at the National Meeting of the Society of Interventional Radiology. There was a peak of vascular presentations from 1997 to 2000, and then there has been a drop progressively, and there has been a growth of the oncology presentations. So that's the trend that we can see now into interventional radiologists going into interventional oncology, and the vascular areas is kind of fading away for a number of reasons. It doesn't matter now. Dr. Rubin showed something about the incidence of cancer. I just want to share with you those two graphs of the incidence of hepatitis B up to 2007 in the United States, and the hepatitis C. And you see the peak of reported acute cases was in 1986, 84, 86 for hepatitis B, but it's estimated that's much higher at that time. And the hepatitis C, apparently the peak was in 89, 90. And the repercussion of that is that we're going to see the HCC population growing, because this is going to, from 86, 88, 90, we're going to see patients until 20 years later, 25 years later. So we're going to see a curve that is going to start growing from here and going up like that. That's the up to 2006, the age-adjusted incidence of rates of HCC in the United States. So it's pretty dramatic, the increase, as Dr. Rubin mentioned before. And when you adjust for age, also there has been a growth which has been pretty significant, especially in men and also in females. So we haven't seen the peak yet of the HCC incidence in the population. Probably going to see that in 2015. They're going to see at least 15 more years of patients with HCC that will need treatment in the next 15, 20 years. So there's a lot of work to be done in front of us. Just to touch on the ChemoEmbolization, which is a technique that has been used for a long time now. It has been actually used in Japan since 1977, I'm sorry. And, but it was not well known in the West until '85, when the Journal of Radiology published three papers on some type of treatment made in Japan for HCC. And there was this landmark paper that was by Ohishi in the issue of January 1985. It's actually interesting to read that. It was a revelation for me when I read that paper. And you see that and this was the first ChemoEmbolization patient that I saw in a publication. So it was one of those moments here, wow, this is going to change the world. And it did. You see here the response of the AFP, and this is 1985. They published about 90 patients treated at that time. And you see here one of those first cases were a large tumor that responded to the ChemoEmbolization. So it was one of those moments that the world changed, and we didn't really notice that. Anyway, so this was shown before by Dr. Thomas, and but you see that most of the patients we see in all this is the staging classification of the Barcelona Clinic liver cancer, and 70 to 80% of the patients we see are within this group here. So patients that really need treatment. And there are a number of treatments now, like radiofrequency ablation. This is one of the first devices that we used that is able to ablate completely some nodules, preferably below 5 or 3 centimeters. And you see here there is a histologic response with all necrosis of the tumor after RFA. If you look at the progression of when you stick the needle in the patient, there is an area of ablation that's rather non-uniform. They say it's a sphere, but it's not really a sphere. It depends a little bit on the device you consider, but it's more of an area around the oval area around the tip of the needle. And you may need to use association of needles to get a larger. The clinical application is for treatment of HCC, liver metastatic disease, et cetera, as mentioned before. One thing that ablation allows you is preservation of the liver. Since in this population, particularly with HCC, the prognosis depends more on the hepatic function than of the volume of the liver not affected by cancer, and than the tumor itself if we can control the tumor. So it's more critical in cirrhosis and HCC. So the approach can be percutaneous, imaging-guided, ultrasound, CT, fluor CT, or surgical direct vision, ultrasound, laparoscopic, etc. The current indications are several, with mostly in patients non-candidate for candidates for resection. Although there is evidence now that's as a primary treatment in guarded the same indications for surgery and RFA. RFA is comparable to surgical resection if the indications are similar. So this is one case. It's a colon cancer that was treated by RFA, and you see here the involution over a period of a few months. This is a patient that we've been seeing for quite a long time now, more than 8 years. Had a very large HCC in the right lobe. This is a CTA, and we did a ChemoEmbolization, and then we associate that with RFA, and that's the patient last year with a very some residual tumor. This patient is still alive. He came actually this year to the hospital. It was is still alive 8 years later. So there is a role of the peri-tumoral vessels in RFA causing the heat sink effect, which is more a problem of radiofrequency ablation, not as much with a new technology with the microwave, and I'll show that briefly at the end. If you have a tumor with no non-peritumoral vessels, the success rate is 93% with very low recurrence rate. If you have peritumoral vessels or more than 3 millimeters, the success rate drops dramatically, around 50%. And if you have, you will need multiple treatments, and the local recurrence is much higher, 20-something%. Association of procedures is, to me now, is almost a norm. If you have this cancer here, it's an HCC, was treated by RFA. We thought we did a good job. We did a follow-up. About a month later, patient came back with a residual lesion there because there was a big vessel just nearby. And then we tried to retreat with RFA, didn't really take care of it. We did a still enhancement there. And then if you do the arteriogram, there is still tumor there. Then we did a ChemoEmbolization in association, and then the thing started to shrink, and the patient got rid of the tumor.